From there, we will hear from Lena Macaroon. Dr. Macaroon is a staff physician and a core investigator at the VA Pittsburgh Healthcare System at their Center for Health Equity Research and Promotion. She's also an affiliate faculty of the VA Pittsburgh Geriatric Research Education and Clinical Center, as well as assistant professor of geriatrics at the University of Pittsburgh School of Medicine. Dr. Macaroon's research examines health-related social risk factors for older adults with a specific focus on elder abuse. Her current work aims to improve detection and response for elder abuse among older veterans in the Veterans Health Administration. And lastly, we'll hear from Barbara Rothbaum, professor of psychiatry and associate vice chair of clinical research at the Emory University School of Medicine in their Department of Psychiatry and Behavioral Sciences. Dr. Rothbaum also serves as the executive director of the Emory Healthcare Veterans Program, a nationally recognized center of excellence for healing the invisible wounds of military service, treating conditions such as post-traumatic stress disorder, traumatic brain injury, military sexual trauma, anxiety, and depression. So we have an incredible interdisciplinary group of experts here with us today, and I know we're really excited to learn from them. So Mr. Brookshire, I will turn it over to you to get us started. I think you're muted.
Thank you. I am deeply humbled to be kicking off today's conversation. So I approach this as an advocate. My story, I think, is really important to understanding how I even got involved in this work. I'm sharing in the chat a one-pager about Black Veterans Project, but also feel free to visit www.blackveteransproject.org while I'm speaking for the next few minutes about our work. So I served for 7 years as an infantry combat medic, got to see a lot up close during that time. And I come from a family of veterans. My father had served for 30 years. My mother is a Haitian immigrant who also served. That's how she met my dad. And I joined up shortly after dropping out of college. After my freshman year, I was a first generation college student, went to Morehouse College in Atlanta, Georgia, and Obama ran for president. I got super inspired by his win, like so many did, found myself in uniform at a time of military conflict, deployed to Afghanistan. I was also serving under Don't Ask, Don't Tell at the time, which was, had its own compounded intersectionalities. That my intersectionalities compounded my experiences in the military in that way. And I ended up transitioning off active duty into the New York State National Guard and matriculated through college and then graduate school in about 3 years. And found myself at the end of my military time after serving for 7 years in 2016 and graduating at the same time. And in the year that followed that, I had a really difficult transition and one that I had not anticipated because on paper, it seemed like I had made a pretty seamless transition. I graduated from Columbia's policy school, landed a great job, but still found myself with an existential kind of crisis of identity that so many vets face when they're transitioning, and also trying to reconcile what the last 7 years had wrought for me. And I could not get decent mental health care from the VA. And because of that, over the course of a year, I deteriorated substantially, and it led to a suicide attempt. And it was when I was in the psych ward, having survived that suicide attempt, that the seed for Black Veterans Project was planted. I read a book when I was in the psych ward called When Affirmative Action Was White. It had been sitting on my shelves in graduate school. I hadn't touched it, but you have nothing else to do when you're locked in four walls. So I read a lot. And When Affirmative Action Was White was written by an academic out of Columbia named Ira Katz Nelson, and it looks at the kind of social welfare policies that precipitated in the 1940s and the 50s that really helped to bolster the white middle class. And it talks about the ways in which Black folk were largely locked out of it. And there was an explicit kind of chapter that was focused on the GI Bill. And I had heard of obstruction to the GI Bill before, but it hadn't really kind of solely landed. And when I transitioned out of the military, and transition out of the psych ward as well, wanting to reconnect with community, had found myself interfacing with a lot of Black veterans with similar stories over generations, right? Vietnam era veterans, Gulf War era veterans, veterans of my generation. And it sparked in me the desire to do a racial equity project, but also to do a project that was focused on reparative justice. And so at the heart of our work, we are advancing the case for reparations for Black veterans, working mostly with Yale Yale Law School. And so over the course of the last 3.5 years, we partnered with Yale to do a pretty substantial FOIA effort, sued the VA for internal data and metrics that it had kind of been hiding from public view around racial disparities and disability access, looking at the last 20 years. And we're able to show through our efforts that there was almost a 30% greater likelihood of denial rates that Black vets faced just relative to PTSD compensation. And we know how substantial and how helpful disability compensation can be. And when you think about the apparatus of basically the welfare safety net that you gain access to, that is so much of a motivator for so many working class people to join the military, because you get access to VA education benefits, of which I've used almost $500,000 to go to school. When you think about the VA home loans, the ability to purchase a home without putting any money down, vocational training, disability compensation, access to VA healthcare, it can be life changing. And so many Black vets have not had equal access for a number of reasons for generations. And so much of our work has been around kind of tying that historical legacy, looking at the initial obstruction around the GI Bill, when the vast majority of Black vets didn't gain access to VA home loans, which created an economic chasm that still reverberates to this day, to then also looking at VA disability compensation, which has been our most substantive work. We were able to get a Government Accountability Office study passed by the Biden administration, which was published this past summer. Also able to begin working directly with policymakers, looking at legislative repair to try to extend VA housing loan benefits and potentially education benefits as well to direct descendants of Black World War II veterans. And so this work is still evolving and expanding, and you can learn more about it. But I look forward to a lively discussion today as we think about the social determinants of health. Obviously, centering veterans, I think, is a really, really important discourse in the public health narrative, because there's an ecosystem that most would want to have replicated outside of just vets in our country, one that would provide access to adequate healthcare and resources to the majority of Americans. So yeah, that's why I'm here, and I appreciate you guys making space for us to be in conversation.
And we very much appreciate having your energy and lived experience and just everything that you have brought kind of historically and from your own personal experiences to be really, it sounds like an entrepreneur in this space. I'm sure there's going to be a lot of questions for you about your work and next steps and priorities. So I'm really excited to learn more. Thank you for that initial background. And we will now turn to Dr. Castro.
Thank you so much, Sarah. It's a pleasure to be here. And I apologize for not using slides. Normally I use lots of data slides, but I'm going to do something a little bit different. I'm going to try to make 3 points. And the first point that I'd like to make is I have been studying transition of military service members back to their civilian communities for over a decade now. And one of the things that I think we all should appreciate is that most veterans transition okay back to their civilian communities. Now, this doesn't mean that there are not some that have problems along the way, as we just heard from Richard. The problems can be significant, and folks, and myself included, and many on this panel, are laser focused on trying to prevent those kinds of problems from happening. So I want sort of all the listeners at least to appreciate that most veterans do transition fine. They go on, as Richard, and make major contributions to society and their communities. It's a blessing to have veterans in your community. And I don't want anyone listening thinking that all veterans have PTSD or homicidal, suicidal, and we need to stay away from them, because that's just simply not the truth. There are some that do struggle, as I mentioned. So just appreciate that. Second, the VA is a great organization. I know that folks like Richard, certainly early on, had major problems. The VA was like the active duty, were struggling to take care of all of the combat veterans that were returning home. The nation was not prepared. We should just admit that. The nation was not prepared for this massive influx of veterans and service members with mental health issues, with physical health issues. The list goes on, but the VA has really, really improved in the last 25 years, and they continue to improve. So for those of you like Richard who had a really bad first experience with the VA, please give them another chance. Be patient with them. They are trying, and they are a great organization. All the research that I've conducted and that others have conducted have veterans who use the VA love it. The real frustration sometimes is getting access and sometimes getting the VA to listen to the issues that veterans are having. And so I would just say, try to be patient. The VA is getting much, much better. So if you visit the VA 5 years ago, that's not the VA today. And then there's an old saying in the VA. I'm not, by the way, part of the VA, so this is not a paid promotional. It's just looking at the data. They say if you've been to one VA, you've been to one VA. And I would say if you've been to one VA 5 years ago, you've been to a different VA. So the VA is constantly improving and changing. Can they do better? Absolutely. Richard highlighted some key points we don't want to overemphasize. So my second point is give the VA another chance. Give the VA another chance. And then I'd like to end by just acknowledging there are major issues around disparity and who gets services, not just within the VA, but more broadly in society. And we really need to pay attention to those. The research that we have conducted specifically highlights single mothers as having a really hard time when they transition out of the military. Also, people of color, African Americans, Latinos also have significant issues. LGBT service members can also struggle. And of course, discharge status and a lot of demographic variables are also very important. I think that the key thing to take away is there are certain groups that really struggle, that kind of put them on a path to homelessness, that put them on a path to not getting a job. And it kind of goes back to the military. Sometimes the military doesn't do a good job of preparing service members to leave. And many service members think it's going to be easier than it is. And, you know, transitioning out of the military, I've argued, is like moving to a new country. So imagine if Castro's moving to India, as an example, what would I need to do? Well, I'd need a job. I need to figure out where I'm going to live. If I have kids, where they're going to go to school. If I'm married, where's my spouse going to do? So all of these issues have to be figured out. But many service members think it's going to be easier than it is. So my third point is, for those of you who are still serving, plan. You cannot overplan your transition out of the military. It does require a lot of challenges, and all veterans tell us it was a lot harder than I thought it was going to be. I thought I had it figured out, but it was harder than I had planned it to be, and actually but eventually veterans are very savvy. Like I said, they're an asset to your community. They figure it out. Richard figured it out and is now making amazing contributions to our society and to other veterans. So I don't want to lose sight of that. So I'm going to stop there. And again, thank you for having me on the panel.
Thank you so much. And I think that both of you have really underscored the importance of understanding and addressing inequalities that exist among veterans. So I'm hoping we can talk even more about that as we continue today's discussion. From here, I will turn it over to Dr. Jane.
Thanks for the introduction, and thank you so much for inviting me to speak here today. I'm a psychiatrist, I'm a PTSD specialist, and I practice at the VA hospital here in Palo Alto, California. And when I was thinking about this presentation today, and when I was thinking about this audience in particular, I felt it might be helpful to share a narrative, because that's really what I feel is the essence of what I do on a daily basis in my work, is listen to stories. And so that's what I'm going to be doing. I'm going to be sharing an excerpt from my 2019 book, The Unspeakable Mind. And what I'll be sharing is the prologue to the book. And just to set this up a little bit, the prologue describes an experience that I had in 2004 when I met a young veteran who just returned from Afghanistan. And I was a resident at that time. I was on the cusp of graduating from residency. And I'm really sharing this piece for a few reasons. First of all, I think it would be very valuable for everybody here in the audience to really know what PTSD is and how it manifests and really derails the life of a human being. And secondly, I think sharing this excerpt will really help emphasize the chronicity of the problem that we are dealing with. As I mentioned, the excerpt I'm about to share took place in 2004. It's now 2023, and it really does hurt my heart to say that a week doesn't go by when in my clinic I don't hear a similar story. Obviously, the names change, the details change, the specifics change, but the essence of the story is kind of the same. And I think that is in part due to the very long nature of these conflicts, and also in part to the chronic consequences of exposure to combat trauma. And finally, I just want to point out that PTSD is a pressing public health concern, not only amongst our veteran population, actually, in the United States in general. And I'm hoping, that will be illustrated in this excerpt that I'm about to read. So I'll start by reading, but I do want to point out that, I'm very particular about not being graphic in the details that I write about, because I don't want to trigger anybody who has a trauma history. But at the same time, I do want to make folks aware who are listening to this that some of the content might be a little bit distressing. The interview room at Milwaukee Veterans Medical Center is small. So before our patient Josh enters, we rearrange the seating so as not to overwhelm him, and we settle on a circle formation. Our team consists of a serious, bespectacled medical student, the psychiatry intern dressed in her standard VA-issued royal blue scrubs, me, the chief resident on the cusp of graduating from residency, and our attending physician, a seasoned senior psychiatrist. Josh has our undivided attention. None of us is preoccupied with our to-do lists or glancing at the clock to check if it is time to move on to the next patient. We are, in a way, entranced, unified in knowing that we are witnessing something significant. Josh's appearance sets him apart. Self-assured with a muscular build, he has a slight tan, his brown hair is cut short, and he has piercing blue eyes. All of 21, he tells us how, along with so many of his friends, he was moved to action by the events of 9/11. He joined the Marines not long after graduating from high school because that was what was expected in his family. Both his grandfathers, a couple of uncles, and a handful of cousins had joined the service, and so had he. Josh was born and raised in a rural town a couple hundred miles north of Milwaukee. He was sent to the, quote, hospital in the city, unquote, because his local VA did not have an inpatient psychiatric hospital. He tells us how happy he was to come home after his military discharge and how good it felt to see family and friends. But those feelings were brief and quickly gave way to strange thoughts and emotions. As he articulates his story, I began a mental checklist. Not long after coming home, I started having nightmares. I would say they are worse than nightmares because they are a replay of stuff that really happened in Afghanistan, stuff I want to forget. I feel everything I felt when I was in Afghanistan: fear, panic, my heart thumping in my throat. I wake up screaming and my sheets are drenched. This happens almost every night and I dread going to sleep. Nightmares, check. Weird stuff is happening when I'm awake too. I can't trust my eyes and ears anymore. I look at everything again and again to be sure that I'm safe. I always feel something bad is going to happen. I can't just relax. Hypervigilance, check. I went to the store with my kid brother once and we were loading up the truck with groceries when a car backfired. I just hit the ground. My body just reacted. I wasn't in control. When I realized it was a car, I calmed myself down. But there were a bunch of people staring at me and some were laughing. I don't care about them. It was the look on my kid brother's face that just killed me. He was scared and looked shocked, like he didn't recognize me. I just felt so ashamed. Exaggerated startle response, check. After that, I just started to hang out more at home. I didn't want to do any of the things I used to love before Afghanistan. Before I went to war, I could never sit still. My mom would complain that I was always out with my buddies at the movies, bowling, fishing, playing ball. And now I didn't want to do any of that. I just sat at home for weeks at a time, drinking beer and staring at the TV, watching dumb reality shows, sort of zoned out and feeling numb. Markedly diminished interest or participation in significant activities. Check. Then I started getting a lot of thoughts about Afghanistan during the day. The slightest thing took me right back. If I happened to flick to news covering the war, then bam, I'm suddenly lost in this other world. Sometimes family or friends would come over to visit, and some even asked, "Did you kill anyone? Did you see anyone get killed?" Their questions made me want to puke. I felt so sick, I would just get up and leave. I started to feel pissed all the time, like I was looking for an excuse to knock someone out. Whiskey calms me down and it helps me sleep too. I don't have the nightmares when I drink, or if I do, I don't remember them as much. So I started drinking more. Avoidance of external reminders that arouse distressing memories, thoughts, or feelings about the traumatic event. Check. I was doing that for months, and then my mom was having a birthday party for my grandpa. The whole family was coming over. I love my grandpa, but the thought of all those people, the noise, it was too much. I started drinking the morning of the party. By the afternoon, I was drunk. It was a barbecue, and this is where it gets vague because I'm telling you, I cannot remember. I remember the decorations, the cake, and then the smoke from the meat on the grill. It just hit me, and I was back in Afghanistan again. Like really there, fighting for my life. I swear I could not help it. If I could have, I would have. I have no idea what is happening to me. The team knows what happened at the birthday party. We read the eyewitness accounts, police report, an emergency room evaluation before we met Josh. He had had a flashback, a quintessential symptom of post-traumatic stress disorder, where he felt a combat experience was happening again in real time. Once the flashback was underway, he lacked the ability to stop it, and he relived all the original emotions of rage and terror. During the flashback, he assaulted family members. He kicked and punched and grabbed one by the neck so hard that it took 3 grown men to pull him off. The police were called, ambulances arrived, and that was what led to his hospital admission. If this had been the 1970s, after the Vietnam War, and before such flashbacks came to be viewed as a hallmark feature of PTSD, Josh probably would have been misdiagnosed with schizophrenia. But this was 2004, and our understanding was much deeper. The VA patients I'd met before Josh were typically middle-aged Vietnam War era veterans whose PTSD looked different. For some, it had been treated and tamed over the decades and was not a major issue. For others, it was entrenched and layered with decades of severe alcohol and drug addiction, homelessness, and suicide attempts. For those patients, their PTSD was buried under all the other problems and just was not the main focus. Josh's PTSD was fresh, florid, and untreated. Josh stares at his hands with disbelief after revealing this altered version of himself. His earlier poise caves into the reality and his face falls to anguish. To my left, the medical student has teared up, and even our attending physician with all her years of experience seems struck by his story. I abandoned my mental checklist. So yeah, that's the end of the excerpt, and I really look forward to engaging in Q&A with the audience.
What a powerful piece to share, and I think really eye-opening for a lot of folks. And there's some great comments coming in already, and hopefully folks are going to have some follow-up questions about that. I'm really grateful that our presenters are sharing such powerful personal experiences as well for us to draw on today. Next, I will turn it over to Dr. Macaroon. Lena.
Thank you so much, Dr. Lipson, and thank you to Boston University School of Public Health for hosting this really important conversation. I'm so glad to be a part of it, and wow, I'm already have gained so much just by listening to the 3 speakers before me. I'm going to pivot to a little bit of a different type of presentation. It's hard to follow that one, Shelley, but I am actually going to be sharing some slides. I think I'm a little bit too much of a rambler to go without some guidance. So give me 1 second. I'm going to share my screen. And Sarah, do you mind just giving me a thumbs up if you can see the slides okay? Perfect. Thanks so much. So as Dr. Lipson introduced me, my name is Lena. I am a geriatrician clinically by training, so I take care of older veterans at the VA Pittsburgh healthcare system. That's the third Veterans Affairs hospital that I've worked at, and so I've been working in the VA for close to 10 years now. And it's also where I trained to become a doctor and to become a geriatrician. And in addition to my role as a clinician, I'm a health services researcher focused on health-related social risk factors for older adults. And in particular, that interest has taken me into the area of elder mistreatment, which is where my predominant area of research focus. But today, what I'm hoping to pass on to you in hopefully no more than about 10 minutes is how we can center older veterans in this conversation. So I'm not going to focus so much on elder mistreatment in particular or my research in particular, but more considerations when we're thinking about the older generation of veterans. So, and let me see. Sorry. Okay, can't do that. That's okay. All right. So first, in case this, I think we probably have quite a mixed audience here. I've been reading the Q&A and a lot of people have personal experience or maybe veterans themselves. But just to bring us all into the same page, the overall veteran population is an older adult population by and large, at least as of now. So this heat map is using data from 2019, but looks quite similar now. You'll see that in many states across the US, the older veteran population age 65 and up makes up around 50%, and in some states, even more than 50% of the veteran population. These trends are changing over time. So this, what you'll see here is on the x-axis, we have different ages all the way up to age 87. On the y-axis, we have numbers of veterans in thousands, and each color line represents a different kind of decade. So starting in 2015 with the blue line, you'll see that the big spike where we have the highest number of veterans is around age 67. And that spike kind of moves to the right as we move forward a decade. So coming up in a couple years in 2025, but actually will kind of flatten out over the next several decades. And that's as we have kind of the aging out of some of the earlier war eras like the Vietnam veterans, which we'll get to in a minute. So this is a trend that we will see eventually flatten out. But right now, and in the years to come, we will have a really large older veteran population. And so it's an important population to think about. So who exactly are older veterans? They're currently estimated to be around 8.5 million veterans in the US who are 65 years and older. And that represents, as of 2023, 46% of all veterans. And if you look at 60 and older, so just go back a few more years, that's actually over half of the veteran population. Unlike younger generations of veterans, where we have women as the most rapidly growing population of veterans, older veterans are still disproportionately men. By a significant degree. So we only have about 5% of older veterans being women. 68% are Vietnam War veterans, and we'll get into that slightly more in a minute. And here you'll see the racial and ethnic breakdown. So 8.6% identify as Black, 1.5% as Asian, a little over 5% as Hispanic, and 3% as another race or ethnicity. So here we see the the war era that these veterans are coming from. So you'll note, so the blue bar is always the most common, and it changes as you look at different age groups. So when we look all the way at the top at the 90 plus, so these are, a lot of the patients I see who are, being sent to geriatrics. It is actually still the most common to have Korean War and actually still some World War II veterans, although less and less. But as you move down in the age brackets by 5-year increments, you'll see that pretty quickly, once we get into the 70s and late 60-year-old age groups, the Vietnam War era is by far the biggest contributor of veterans to this older adult population that we're seeing. And this is really important to understand because veterans from this era experience a lot of things that were unique for military service. Number one, they may have joined the military as part of the draft, so it may not have been a voluntary decision to enlist. And also on return home from the war, they faced a lot of challenging things societally with, public opinion about the war in Vietnam, and faced a lot of re-traumatizing experiences when they came back. So when we look at the overall population of older veterans compared to non-veteran older adults in the United States, older veterans actually do enjoy a number of kind of benefits in terms of health and social status. So for example, older veterans are less likely to live alone. They're more likely to be married. In the graph on the right, you'll see that they are less likely to experience social isolation compared to non-veterans. And they're also less likely to experience poverty. However, not surprisingly, based on military service and kind of subsequent health conditions that may result from that, they are more likely to have a disability. So this is when we just look at the overall veteran population. But what about those who receive care and are enrolled in the Veterans Health Administration? So this is, the VA being, 3 different branches: VBA, cemetery, and VHA, which is where healthcare services are delivered. And this is where I work. What about veterans who receive care there? And these are the vets that I take care of on a daily basis. So only 41% of all older veterans are actually enrolled in VA healthcare. And the veterans who do receive care in the VA tend to be lower income, have had less education, they've experienced more trauma, are less likely to be married, are more socially isolated, and more likely to identify as Black or coming from other historically marginalized races and ethnicities. You'll see in the graph on the right that veterans, when compared to both veterans who don't get their care in the VA as well as non-veterans, veterans who get their care in the VA have higher rates of cancer, diabetes, as well as mental health conditions and post-traumatic stress disorder. So overall, in the VA, we treat a sicker and more complex, both health-wise and socially, population of older veterans. And this is really important to think about because not only do all of these things impact the health of the older adults that we treat in the VA, but sometimes they can also coalesce to create risk for other kind of complex psychosocial geriatric syndromes or for, psychosocial phenomenons. And one of those is elder mistreatment, which I'll get to in a moment. So what I'm highlighting here are different ways in which VHA enrolled older veterans may compare to non-veterans specifically. So higher rates of depression and PTSD, more likely to have 2 or more chronic health conditions, and more likely to rate health as fair or poor than older non-veterans. And more than half of older veterans who get their care in VHA report difficulties in physical functioning. So this is really important for independence as we age. There's a very high prevalence of dementia, and this may come from causes that are not the same as causes in the general population. So we have a higher prevalence of TBI or traumatic brain injury related cognitive decline, as well as substance use disorder related cognitive decline. And around 40% report loneliness, and over 50% may experience social isolation. So, people, older veterans in the VA have a lot of these different conditions. And like I mentioned before, these can coalesce to also put them at risk for other types of phenomena, such as elder mistreatment. So what is elder mistreatment? This is physical, psychological, or sexual abuse, financial exploitation, or neglect of an older adult at the hands of a trusted other. And based on what we know about risk factors, which you'll see kind of outlined in the outer bubbles here, veterans who receive their care in the VA, who are enrolled in VA healthcare, have a really high prevalence of all these risk factors, including cognitive impairment, substance use disorders, social isolation, mental health problems, functional impairment, and then financial dependency and hardship. And this kind of goes both way because as Richard was mentioning in his talk, a really great thing from the VA are financial benefits such as disability compensation payments and pension payments, which can help if you're facing financial hardship. But these things in my research, we're seeing that they may actually also increase the risk of financial exploitation. And we also know that there's a huge preponderance of scams and financial scams targeting, in particular, older veterans, and because of these financial benefits. So another thing that I think we have to consider when we're considering any older adults, but especially older veterans as well, is what is it that they're facing in the healthcare system, but other institutions, as they then try to kind of confront and manage these different health conditions and social conditions as they age, and that is ageism. So what exactly is ageism? It's stereotyping, prejudice, and discriminatory actions or attitudes based on chronological age. So stereotypes I think of is as how we think, prejudice, how we feel, and then discrimination is the culmination of how those stereotypes and prejudice translate into how we act. This quote by Louise Aronson from the book Elderhood, I think captures it really nicely. For more than 5,000 years, old has been defined as beginning between the ages of 60 and 70. Now that humans are living longer than ever before, many people alive today will be elders for 30 years or more. Yet at the very moment that most of us will spend more years in elderhood than in childhood, we've made old age into a disease, a condition to be dreaded, disparaged, neglected, and denied. So these are a lot of really negative and really weighty connotations with even the idea of getting older and with the identity of being an older person. And then these are things that then get packed onto other identities that we have that may also experience disadvantage. And so here comes intersectionality, which also layers on top of military and other healthcare experiences that may have been traumatizing and impacting for people. So in particular, and this is not exhaustive on this slide, but ageism can interact with experiences of racism, experiences of ableism, which is particularly important among the disabled veteran population, experiences of sexism, again, which have been exacerbated through military experiences, homophobia. Richard again mentioned don't ask, don't tell, which replaced a previous policy where, you couldn't even serve in the military if you were gay. So lots of intersectionality here that can impact people's experiences. And so what are the ways that I want to, encourage people to think about approaching affirming care for older veterans? So one idea that I want to communicate is something called the life course approach. And I think this is really relevant for veterans, but of course all older adults. And the life course approach embodies theories that explain how socially patterned exposures at different stages of human development shape health within and across generations. So this is the idea that you can't just look at an older adult at one moment in time when they've reached adulthood and look at their current situation and think that that's going to give you the full story of how they got where they are. There's two main perspectives here: the developmental perspective, which is the idea that there are sensitive life stages under which an exposure during a sensitive life stage may be more likely to actually set you on a certain health trajectory. And then there's also a structural perspective. So this is, aligned with something called the weathering hypothesis, but this is essentially the idea that kind of repeated stressors over a lifetime create an allostatic load, so to speak, to lead to poor health outcomes. And so, like I said, when we look and have an older person in front of us, I want you to see this, is the idea that everyone comes to whatever point they are in their life with a whole lifetime of experiences beforehand that are all important for understanding where they are there at that point in time. And I think from a research perspective, it's really important that researchers who are doing aging related research and doing research with older adults and older veterans actually think about the entire life course and not just about exposures that people experience in older age. And so finally, what are the types of things within a healthcare system framework that we're trying to do to make sure we're addressing the needs of older adults and older veterans in particular? So one is called the Age-Friendly Health System. So this is an effort funded through the John A. Hartford Foundation and Institute for Healthcare Improvement that you may have heard of or maybe hearing of more, as I think all healthcare systems are kind of confronting caring for more and more older adults. But it's based on
It looks like Lena has frozen for just a moment. We will send good
physical
vibes.
function.
Oh, there we go. You froze for just a moment.
Oh, I'm so sorry. Okay. Well, I was just going over briefly the 4M.
Great. It looks like she has frozen again.
So function, so not just cognitive health, but oh no.
We've got you back again. We got you back again. So crossing.
Oh shoot.
No, go
Okay.
for it. Go for it.
Okay, well, this is my second to last slide, so hopefully we'll make it through. But so let me skip over the rooms. I'll focus on the one that I think is most important, which is what matters. And I think for veterans in particular, this is so crucial. So really centering the care we deliver, the services we deliver, the design of those services around what is important to veterans and making it really veteran centric. And I will highlight that the VA, to Dr. Castro's point, is actually a big leader in the age-friendly health system movement, and we're kind of making lots of strides towards making all of our facilities age-friendly. So to kind of end some ending points, how can we support what matters most for older veterans? I think it's really important to think beyond just the individual veteran, but to their social network, to their caregivers and their families. A healthy, caregiver is a healthy dyad. We can't just be thinking about the veteran. We need to be supporting caregivers and families as well. Providing services for health-related social risk factors. I think someone did bring up social determinants of health at some point, but we know that this is a major driver for health beyond and even more important than healthcare. So we need to address these things for older veterans. Veteran-centered aging in place, so innovative programs that go into the community and help veterans stay in their homes as long as possible if that's what they want. Comprehensive care for cognitive and behavioral health. Services to maximize function. And so here we're thinking about things not traditionally covered under Medicare, like vision, hearing, durable medical equipment, rehab, and fitness. These are all things that the VA really leads on and provides comprehensive services for those who qualify. Care aligned with goals and preferences at all health stages, so not waiting until end of life to really talk about what's important to people. And then making sure that all the care we deliver is anti-ageist, equitable, and trauma-informed. Thank you so much.
Thank you so much. I think there's so many themes that are coming across in hearing each of our presenters today and thinking about kind of the heterogeneity and diversity of veteran populations and thinking specifically about the needs of older veterans is very important. So I'm so glad that you're here on this panel. Next, we will turn it over to Dr. Rothbaum.
Thank you. And I'm so grateful to be here today and be part of this conversation. I'm going to talk about treatment of PTSD. First, I'm going to talk about standard treatments. And we have 2 FDA-approved medications for PTSD, sertraline or Zoloft, and paroxetine or Paxil. And that's great that we have 2 FDA-approved medications. Some of the challenges is I don't think anybody thinks that they're really the treatment that we need for PTSD. The response rates are really not good enough. So most of what is recommended are cognitive behavioral treatments for PTSD. And there's several trauma-focused therapies that are recommended. You'll see at the bottom, prolonged exposure has the strongest evidence to support its efficacy for PTSD. So for the rest of today, I'll talk mainly about prolonged exposure. We do have a number of good treatments for PTSD, so that's great. Some of the challenges is PTSD is a disorder of avoidance, and that includes the treatment. And so they're pretty high dropout rates, and not every treatment works for everybody. And even if it helps a little bit, sometimes it doesn't help remit. It doesn't help. We don't tend to use the cure word, but we have ways that we can go to improve our treatments. In general, what we do with treatment for PTSD is helping people to confront the memories of what happened to them, but in a therapeutic manner so that it changes. We've got two main components of prolonged exposure therapy. Imaginal exposure, briefly, we ask the person to close their eyes and go back in their mind's eye to the time of the trauma and recount it out loud repeatedly. We tape record that and ask them to listen to it for homework. So they're constantly emotionally processing what happened. We also do what's called in vivo exposure, and that just means in real life, where we help people confront situations that they've been avoiding, but that are realistically safe. PE, prolonged exposure, is recommended as a first-line treatment in every published treatment guideline for PTSD. So that's the standard treatment. Now I'm going to talk about some new approaches. The first is the medium of delivery of exposure therapy, and that's a little bit on virtual reality.
We will begin takeoff momentarily.
That's the virtual airplane, which is actually my favorite because I can exactly control to make sure that everybody's getting the perfect exposure. If they're not ready for turbulence, I can guarantee there won't be turbulence. We can take off and land as many times as we need to, all within my 1 hour therapy session without leaving my office. We can treat heights, fear of elevators. We've got stuff for people with substance use or substance misuse problems. Here's our virtual bar. Now, going back to PTSD, the first time that we treated PTSD with virtual reality, it was with Vietnam veterans, and we did find it useful. And so now we're using it with veterans who served in Iraq and Afghanistan. So they're still doing the imaginal exposure to their most traumatic memories, but now their eyes are open and the therapist is matching in the virtual reality what the patient is describing. This is what it looks like. People wear a head-mounted display, and that immerses them 365 degrees. We can put someone in the situation that matches almost whatever they experienced in Iraq or Afghanistan. We can put them in an MRAP or a Humvee, change the time of day, put them whatever position they were in a vehicle, at a checkpoint, on a forward operating base. Just a little clip to show you what some of the capabilities are. And this isn't what the patient would see. Because this is basically a little movie I'm showing you. They would be seeing it in the head mount display. So they'd be totally immersed.
Roger.
And they would only be seeing what they're describing. So next innovation, enhancing exposure therapy with pharmacological agents. In general, most of the studies have been done combining PE, prolonged exposure, with an SSRI. Remember, Zoloft or sertraline, paxloproxetine, and in general, PE is just as effective with or without the SSRI medication. And both guidelines, VA-DoD and APA treatment guidelines for PTSD, do not recommend the combination of evidence-based psychotherapy like PE and SSRIs. What people are excited about, what people are thinking might be the next medication to be FDA approved for PTSD is MDMA combined with therapy. And we're about to start a study combining MDMA with PE, with prolonged exposure. So we're very excited about that. Now, next innovation, timing of exposure therapy. Most of our veterans come to us about 10 years after they return from deployment. So that means they have been suffering for a long time. We know that what happens right after a traumatic event can help or it can hurt. Obviously, we want to help. So we've done some early intervention studies in the emergency room where we did basically exposure therapy right after someone was exposed to probably the worst thing in their life. And we found that 3 months later, if they received the early intervention, that's in blue, they had half the rate of PTSD of folks who didn't. And it looks like it might have mitigated a genetic risk for PTSD. Last innovation I want to talk about is masked PE. So most of us, when we do therapy, we see patients once a week. In the Emory Healthcare Veterans Program, we have built an IOP, an intensive outpatient program, a 2-week IOP that we can fly in post 9/11 veterans from all over the country. We put them up in a hotel, we feed them, and we give them more therapy in 2 weeks than most people get in a whole year. Everything is at no cost to the veteran. We do family therapy. We individualize treatment. So for example, if they have substance use disorders or substance misuse, we have a SUD track. If they've got issues with mild traumatic brain injury, we have a TBI track. We've treated over 1,000 warriors this way. And in some ways, this is the number I'm most proud of. We have almost 93% completion rate. I really think this is the secret sauce to treating PTSD because it helps combat the avoidance. It helps break down so many barriers to care. And it's effective treatment. This is PTSD symptoms on the PCL. And this first line, that's the beginning and end of that 2-week IOP. And then we follow people for a year. So they're getting large gains, improvements in their PTSD that they're maintaining for a year. And similarly for depression. What we also found is what we thought, when you treat the PTSD, the suicidal thoughts decrease as well. We're also gathering psychophysiological measures before and after treatment. And we're seeing that when you give them good treatment, that their bodies are learning to become less reactive. The startle response is decreasing, heart rate reactivity to responses to activation are decreasing. So that makes me so happy that our veterans' bodies are learning to become less reactive to these cues. This is a book we wrote for the lay public, and this is our contact information. If you want to send us your veterans or active duty service members, hopefully we can send them back to you better. And with that, I'll stop sharing.
Thank you so much, Dr. Rothbaum. And I feel so grateful that you are doing this work and doing it in such a thoughtful way that is clearly protecting the individuals that you're serving and customized and tailored to their needs. So we have some great questions that have come in already from guests today that I definitely want to make sure that we turn to. Looks like all of our panelists have already turned their cameras back on so we can see everyone. So I'm going to maybe, I think, ask one or two questions to kind of kick us off, and then I want to turn to some of the questions that have come in from the audience. And then at the end, I want to turn to each of you and see kind of what takeaway you want the attendees today to come away with. So we'll kind of organize the next 25 minutes or so in that way. To start us off, I am curious, and I think this is inspired by many of your comments and the work that you're doing, but to think about what are the things that bring you hope right now in terms of the ways that we can be centering the needs of veteran populations. What are the things that give you hope and make you feel optimistic about this work moving forward? I'd love to hear from each of you on that.
I'm happy to jump in. I think the things that give me hope is how much traction our work has gotten over the course of 5 years from the real grassroots level. And the fact that there's now a movement for real transparency by the VA around these racial inequities, access to the data in ways that were never really kind of publicly available, which I think are going to be critical to measuring how we can make an impact and continue to make an impact with respect to the disparities, specifically around like disability compensation. I think that that's such a huge driver, and obviously kind of beginning to hold the VA accountable around the racial disparities relative to PTSD care. I think that's super critical, and I'm very optimistic about that.
Thank you. Do others want to chime in with thoughts?
I think I'm also, sharing in that optimism. I mean, if you look at the last 20 years, if you just look at PTSD science, what we know about it as a condition, what we know about what treatments work, what doesn't work, there's been an exponential growth in what we know about PTSD in the last 20 years, partly because of the wars in Iraq and Afghanistan, things like the Great Tsunami, things like Hurricane Katrina, massive amount of research that has been done. We just know so much more now than we used to know. So, when I was starting out in my career, PTSD was sometimes considered like disabling and incurable, and I don't view it that way now at all. It's something manageable. People can live with this condition. It doesn't have to define the rest of their life. So I think in that sense, it's really good. A few things that I'm seeing on the clinical fronts that make me really excited. We've done a lot of work to include peers in the treatment of mental health conditions for veterans, peers, PEERS, because I do think one of the massive barriers culturally to veterans seeking help is that, especially mental health help, is that, why should they open up to somebody like me who is not a veteran, who does not have a lived experience of combat, who on the face of it, I might not look or sound like them. These are some of the barriers we have culturally. So a lot of my research has involved integrating peers into the treatment of PTSD. And I think that reduces some of the barriers, because I think having veteran peers who have that lived experience and who can be a beacon of hope and recovery and who can share their experience really helps with adherence and with engagement in treatment. Another thing is primary care mental health integration. So the clinic that I work at the VA in Palo Alto, it's a really cutting edge clinic in that we're literally embedded with primary care. So these kind of artificial barriers, this artificial mind-brain distinction, which is a fallacy, is just broken down when we're all working in primary care together. And I think that reduces a lot of the stigma about seeking mental health. When you're seeing the doctor whose office is next door to primary care doctors, there's less barriers. And then finally, one thing that came out of the pandemic, obviously we were all forced to really embrace virtual care. And anecdotally, I don't know if there's data to back this up, but I've noticed pre-pandemic, we had a no-show rate of about 20% in the VA. And by no-show, I mean a veteran is offered an appointment, but they don't come for it. 20% is pretty high from best I know compared to community samples. One thing I've noticed since the pandemic, because we're doing a lot more video care and a lot more telephone care and it's become a lot more acceptable, it feels to me my no-show rate is virtually, it's really low now. And I feel like I'm reaching people who do have barriers to come to the clinic, either psychological or real barriers. Like real physical barriers, either they're working or they're in school, and offering this modality is just really helpful. So those are some of the things that make me really helpful. And to address the comments about, inequity and reaching people who historically have been underserved, I do think that that virtual element has been really rewarding. I feel like I'm seeing people who maybe I wouldn't have seen before. So those are some of the things that make me feel really hopeful and optimistic.
Great, thank you.
I'll be brief. You heard what makes me hopeful. I'm thrilled with our program, with our IOP, that we're breaking down barriers and it's effective in keeping people in treatment. And I agree that there's so many innovations going on now. In looking at the treatment of PTSD over the years, over like hundreds or thousands of years, in some ways it is military psychiatry, military psychology. So although wars are terrible, innovation comes out of it because we want to help our veterans who put themselves in harm's way. So we've got some good treatments, and I can think they're only going to get better.
Yeah, I will just chime in to say, in the world of elder mistreatment, one thing that makes me feel really hopeful is this has historically been a really understudied and underattended to problem. It's extremely common. 1 in 10 older adults in the US experience elder mistreatment every single year, but we know so little about it. And one thing I'm really excited about is that the VA and research and program development in the VA is really leading the charge for innovative kind of approaches to addressing this that I think could translate out to kind of impact the population outside the VA as well. So I think it's, broadly speaking, our culture and society in the US and our institutions and structures are not set up to kind of have just holistic responsibility for people's well-being in the same way, for example, within a healthcare system, it's the financial structures are not set up so that you just kind of holistically care about someone. Whereas in the VA, I feel like our structure is different, where we can actually do a lot of innovative things to kind of consider social risk factors and functional health and mental health and all these things, and sensory impairments, and kind of holistically consider the whole person and the whole veteran. And I think that approach, I'm hoping, is going to translate into people seeing that that's what is really needed, and certainly for complex situations like elder mistreatment, but across the health spectrum for older adults. So that gives me hope.
And I would just add that Lena's work is just phenomenal. I will tell you, 10 years ago, no one cared about old veterans in America. And I think primarily because they were white old men, and white old men are the least studied, the least understood group. And so when I see inclusion being expanded to include other groups, that just gives me comfort. And this life course approach that Lena has really led the world on, I would say, has just been phenomenal. And I just hats off to Lena for taking this holistic approach and really embracing it. It's really difficult to do. And I'm just thrilled to see the inclusiveness, Richard's work with addressing African-American and Black disparities that exist. The VA has been a big leader in all kinds of disenfranchised groups, including LGBT, women. So it's just been really fascinating. I would love to see a bigger and larger discussion on discharge status and those veterans who served who were discharged for various reasons that were less than honorable, that exclude them from many of the benefits that veterans are entitled to. That's a really important issue. And also, I'd love to see the inclusion of immigrants who joined the military and went to combat and came back and got into some minor infractions with the law enforcement and then were deported. So we have combat veterans who served in our military who have been deported. And I just think that's not fair. That's probably for me one of the greatest injustices that I have seen. And you know, but I'm hopeful that folks are beginning to think about these topics to broaden the inclusiveness to include these other groups.
Great. I think that given the urgency of this topic, it's no surprise that there's a lot of questions coming in, and my hope is we can get through as many of these as we can. Carl, it looks like you flagged that first question, so maybe you could weigh in quickly about any improvements within the VA and the veteran community related to stigma around mental health and getting support for PTSD and depression.
Well, I flagged it, but it was only because I was going to say this is a tough problem. I mean, there's a real stigma around mental health, not just within the military, but within the military communities, but within U.S. society and within world society. So it's a earth culture of stigma around mental health and physical health as well. We don't talk about that very much. But there's also this stigma around physical health. It's why we have HIPAA, because nobody wants anyone to know about their physical or mental health status. That's because we're concerned about how that information will be used and how it will affect us. And also the culture, and Richard brought this up with the identity, the importance that the military identity is one of which individuals solve their own problems. And so I'm a big proponent of research and folks putting, if you will, self-help techniques that are evidence-based into the hands of veterans and really everyone, because then you're likely to get the veteran engaging more in self-help. But there's a lot of self-help out there, as we all know, that's not evidence-based, that's taking advantage of people's lack of knowledge. But to the extent that we can improve self-help, self-aid, however you want to talk about it, I think that's a real important way of reducing stigma, because when people utilize some of these techniques like mindfulness and yoga, and I saw some notes that was put on there, then people are more likely to see mental health as being helpful in to reduce the stigma, but they have to have that personal experience for that. So I'm sorry I didn't really answer your question about stigma reduction efforts. The U.S. military spent hundreds of millions of dollars on trying to address this issue. We're making slow progress, but it's a tough one.
I'll jump in because we've been trying to address the self-help. We just published a book that's basically self-help exposure therapy, making meaning of difficult experiences. And we've got an app now that we're testing because, like Carl said, we need evidence-based. We need to show it works. We've got an app called Messy Memories that's basically the same thing to help people confront and process difficult memories.
Thank you. And turning to another question, I mean, I think that a lot of the discussion today is about some of the unmet needs and trying to meet needs within the current VA system. But there's a great question here about just acknowledging, many veterans don't seek care in the VA, and what can we do to help support and train clinicians and providers in the community, so outside of the VA, to be able to identify veterans in their own communities and to provide supportive care for veterans.
So I can take a stab at some of that. Oh, and then I'll turn it over to Barbara. But quickly, I do think that's really important. We have to remember, and that's why I tried to point out in my presentation too, like kind of this distinction between VA enrolled and VA non-enrolled, because, most veterans are not VA enrolled. But I think that that's why it's important for all of us to kind of build bridges across systems. And so many things are still siloed, which is really difficult. But for example, in my own work, where elder abuse detection and response is a very interdisciplinary approach, where adult protective services, for example, may be at the county level, and we're here in the VA, which is federal level. So we've done a lot of work to try to kind of do presentations to APS about veteran related health issues, about military culture, about VA services, and about kind of health related issues for veterans. So for example, educating about TBI, educating about occupational exposures, which is really big, of course, for Vietnam era veterans, as well as others. But I think that you're right. And there does need to be kind of a lot of us who work in VA, I think, do also have other spheres where we work. So for example, I'm also at the University of Pittsburgh. And so I always take every opportunity when I'm giving talks or teaching students or, teaching to insert that in there. So it's not a systematic approach, I wouldn't say, but I think just taking every opportunity to kind of educate is really important. So I'll let Barbara add in.
I can refer people to the Center for Deployment Psychology. They offer a lot of trainings to community and civilian folks. We have a training that we're training people in prolonged exposure. So there are a number of programs across the country that can offer military and PTSD and evidence-based treatment training.
Fantastic. There are a few questions around the use of virtual reality and a few around the use of virtual reality, virtual therapy for which conditions. So obviously we talked about PTSD, if there are other conditions that you're applying this to, as well as whether this is covered by insurance.
Yeah, I'll take those. I'll take the VR questions. There are a number of VAs across the country that do have the virtual reality, and if they have it, then it is covered under the VA. And there was a question about, is there anxiety? But I mean, in general, for exposure therapy, it's, we want the dance between tapping into that anxiety, but not being overwhelmed by it. And so hopefully that's where you have a good therapist who can, I tell patients, I'm going to push you out of your comfort zone, but not out of your safety zone. And so we want to help people confront these things, but in a therapeutic manner so that it gets easier and it gets better. And so that's part of the art and science of it. We've got the virtual reality exposure therapy for a number of disorders. So we use it for PTSD. You saw fear of flying is actually my favorite just because it's so feasible. We've got a virtual bar for substance use disorders. We've got virtual audiences for fear of public speaking. We've got virtual relaxation. So there are a number of them out there, and they're only now, things are getting into cheaper and cheaper head-mounted displays. And so I think there's going to be more available soon.
Great, that's really exciting. Another question that has come in is about resiliency training. And I think I'm particularly interested in a lot of what's been said around what can we do at a structural or system level and putting less of the onus on the individual. But of course, and resilience isn't just at an individual level. Of course, we can have resilient systems as well. But I wonder if anyone can talk sort of from the prevention perspective around how resiliency training is incorporated into resources for veterans. Is that something that anyone has any specific experience in? If not, we can address that question offline, follow up. Looking at the time and knowing that I think my next prompt for folks may, take a minute or so for each person to have a chance to respond to this. But so I think we'll turn to that now and just hear, what do you hope, are the biggest takeaways that people leave today's discussion with? Like we've said, there's so much urgency around addressing the needs of veteran populations, both physical and mental health. And so Based on your work and looking, moving forward, what do you hope that people are going to come away with from today's discussion? And we can go in whatever order, folks.
I can start because I definitely, I want people to know that treatment works. A lot of our veterans will say, why should I engage in treatment? My life is ruined because of what happened to me, and you can't change what happened to me. Yes, it is likely awful what happened, and we can't change that. But to help them understand the problems they're going through now, and we help understand what they are. So if it's PTSD or depression or substance use, that we can treat. And so I really want to put out there a message of hope, and kind of like Carl was saying, even if you tried to get treatment, and Richard too, I mean, if you tried to get treatment and it didn't work, try again, try a different provider, try a different place, try a different kind of treatment. But treatment does work. So please have hope.
Yeah, I'll go next. I think what I'd like people to leave with is that equity is possible, that the VA, unfortunately, given its history, it was kind of built on a level of prejudice. I mean, it's endemic in our society, but the need for greater transparency allows for greater accountability. And we're already kind of seeing how disparities in the past when it comes to being able to service women, which there's still strides to be made, but certainly there has been immense strides, right? And so, yeah, I think that that's what I want folks to really censor, and that it's also necessary. Equity is really necessary, a component of the broader discourse. And for me, like culturally competent care is like critical because not every veterans are not monolithic. It's a broad population, a lot of different experiences. And so I think that that's a critical pathway to being able to foster a greater level of equity. And so that Black vets, for all the different reasons that they haven't been able to get equitable access, that we're really making that targeted approaches to ensuring that greater equity is achieved. But yeah.
Do you have a sense, Richard, from your work, like if you could kind of wave a magic wand, are there things that you would think, we could change this and it would really improve the lives of Black veterans?
Yeah, I mean, I think one is targeted outreach. I think some of the work that we were doing over the course of the last 3 years was helping to build a kind of ecosystem, a coalition of Black veterans organizations that are kind of strung out across the country, mostly poorly resourced, often fighting for decades to try to kind of raise the banner because they've been largely neglected by the broader kind of white-facing veteran service organizations in the country who just haven't looked at race as a critical factor to address. And so that population has been neglected. And so trying to organize them, I think has been very interesting. It gives me hope. It's not easy work, but it does give me hope that the solutions are in the community, right? And so making sure that the VA is engaging with the community and not just thinking that, oh, well, because they engage with the American Legion, the VFW, the moneyed veterans organizations that for multitudes of reasons have a racial blind spot historically and in today, that's sufficient. It's not sufficient, and the data is proving that that's why these disparities are persisting. And so encouraging the VA, and whether it be at the local level, at the national level, to really have a targeted approach in how they reach Black veterans.
Great. I'm really glad that you're able to articulate that and also to have a seat at the table today and this conversation is so important. So thank you. Do others want to chime in with some final takeaways?
I'll jump off that and very quickly because I think it's segues nicely, but I wanted to say something similar in terms of veterans are not a monolith. We always say in geriatrics that older adults are actually the most diverse population across the age spectrum. So if you look at 2 5-year-olds, they're going to be pretty similar. 2 20-year-olds, they're going to be pretty similar. If you look at 2 75-year-olds, they could, in terms of what they can do, their cognition, their function, what they're doing with their lives could probably very different. And I would say the same with veterans. We oftentimes will kind of make statements about vets or veterans, the veteran population, but while there are, some commonalities and experiences and kind of culture, et cetera, this is a very heterogeneous group, especially older veterans. And I just think it's important for us to all remember that and kind of treat still, think with an individual lens, even while we think about population health.
Thank you.
And I might just add some thoughts specific to post-traumatic stress disorder. I do think, as I mentioned, it is a pressing public health concern, not only amongst the veteran population, but in the United States generally. And I do think one of the ways of reducing stigma is we just have to elevate the public health literacy around trauma. The odds are, if you don't have a trauma-related issue, you know or love somebody that does. That is just the statistical odds. So I think moving towards being a more trauma-informed culture and society is really going to be key to kind of transcending some of these intractable problems.
And I would just like to add, sir, I know that we were running out of time. A lot of veterans don't access the VA, or they don't access care in general. And I think we need to be respectful of people's decision and veterans' decision not to seek care and not to seek resources, but to be there for them when they're ready to seek care. So, in America, you have the right to refuse help. And I don't like seeing it. I want to jump in there and help. But if someone says, I don't want any help, I want to be left alone, I think we need to be respectful of that decision, but be there for them when they're ready to receive help, and then receive help in a caring, supportive way. I'll stop there, but I think I made my point.
I think that really underscores the importance of having, a public health priority in addition to a healthcare system that is there and ready for folks when they engage in it, but to have a public health approach that reaches everyone. Thank you all so much. This has been extremely insightful. There's so many comments coming in of how helpful and interesting this conversation has been. I will turn it back over to you, Dean Galea.
Well, first of all, thank you, Professor Lipson, for excellent moderation, and thank you to our whole panel. It really is a privilege to listen to all of you and to learn from you all. And really, I know many of you, and I've learned from you over the years, and I learned even more today. I want to thank the audience and the participants. Really, been some very interesting questions, some excellent comments in the chat, and I always feel these conversations are a conversation as we hear from people who are participating and hear their perspectives. So I want to thank everybody for being a part of this. And I want to thank you all for what you do. This is, as we've heard from many of the panelists, we're dealing with a population that's often underserved, and it's people in this room today, both on the panel as well as participating, who are making a difference in people's lives. So thank you to everybody. We set for ourselves the title of this panel to try to center the health of veterans within public health, and hopefully it's conversations like this that do just that. So everybody, thank you for joining us today, and thank you for what you do every day. Everybody have a good afternoon, have a good day. Take good care.